So, I mean, as clinicians, you know endometriosis better than me. The way it has affected the health of almost all the women at different ages. I mean, we know very well that it's a very sort of an heterogeneous disease, which could be just an ovarian endometriosis to superficial endometriosis to deep endometriosis. And we also know that it can involve any organ in the abdomen. It's GI, GU, anything in the pelvis. There are reports of, I have seen one liver endometriosis. There are reports of thoracic endometriosis, etc. So it is very important that before you go in, you know what is the extent of the disease, because the type of surgery which you're going to do depends largely on, of course, what is the extent of the disease. And for this, not only should you know that, but when you choose your team or when you plan your surgery, you need to know what sort of a surgery you're planning and whom do you want to help you. For you might involve a neurosurgeon for some help. You might involve a GI surgeon. So, I mean, at the back of your mind, you have to have a very clear idea about what you're going to encounter when you put a scope. And this is where imaging comes into picture: ultrasound, CT, MR. And being an ultrasound person, of course, I'll focus more on ultrasound. And especially in endometriosis, ultrasound is the first modality. Very often, it may be the last modality as well. Now, the reason why ultrasound is the modality is because the resolution of the present-day probes is phenomenal. And you cannot have any other imaging modality, whether it's MR or CT, which has resolution as good as ultrasound. Today, we are able to look at tubes, we are able to look at femoral ends of the tubes, etc. Number two, it is the only modality which is dynamic, and especially in endometriosis, where we need to do some dynamic tests, as we'll see as we go along. It is the modality of choice. We cannot have a dynamic. We do have a dynamic CT, but that is for a different situation, or a dynamic MRI for that matter. Moreover, we now have a lot of new advances in ultrasound, like elastography, contrast, which we'll touch upon. But as far as endometriosis is concerned, there are two new techniques which we are using. One is a gel vaginosonography, and the other is what is known as saline sonopodography. So we will touch upon these new techniques also as we go along in the talk. So typically, when we look at a patient who is suspected to have an endometriosis, we follow the IDEA guidelines, which were probably published in 2016, but which are very good even as of today. So this consists of 4 parts. One is a routine evaluation of the uterus and adnexa, looking out for sonographic signs of endometrioma in the ovary, adenomasses in the uterus. Then the second step is looking for soft markers, looking for site-specific tenderness. This is where ultrasound scores. We can look out for a point of tenderness. We can check the ovarian mobility with real-time ultrasound. Then the third step is looking specifically at the pouch of Douglas using what is known as a sliding sign, which we'll talk about. And the fourth step is looking for deep endometriotic nodules anteriorly and posterior, in the anterior and posterior compartments. Again, we do in a very systematic manner. Now, the difference between ultrasound for endometriosis versus a routine ultrasound is twofold. One is we would like the bowel to be prepared, unlike a routine ultrasound where we don't do a bowel preparation in a day-to-day practice. Number two, we in a routine transvaginal scan, we always ask the patient to empty the bladder, whereas here we keep the bladder slightly full because we want to see the base of the bladder, the posterior wall of the bladder. We want to see the ureters as well. And therefore, we keep the bladder slightly full as compared to a routine ultrasound. So the first step is looking at the uterus and ovaries and finding out whether the patient has an endometrioma in the ovary, and number two, whether there are any signs of adenomasses. So when it comes to the ovaries, we identify endometriosis in the ovaries by what is known as, so we just look at the lesion and say this is endometriosis by what is known as a pattern recognition. So by now our mind is set that when you see a cystic lesion like this with internal echoes, which are fine, ground glass sort of an appearance, with some sort of nodules like this within the lesion, this is endometriosis. And this comes through experience. And most of the times, 99% we would be right when it comes to saying that this is endometriosis, just by looking at the pattern of the endometriosis. This is an artificial intelligence which we have developed, or everyone who does ultrasound develops over a period of time. So that's the same patient which I operated upon. Now, if there is a doubt, we can use newer techniques like elastography. If you feel, is it really cystic or is it some element of solid within it, we can use elastography, or more specifically, we can use contrast. Now, ultrasound contrast, a lot of people may not be aware, are basically microbubbles which are injected intravenously, and these are gaseous agents, extremely safe because they are not excreted by the kidney, and we get blood flow information at the level of RBCs. Why? Because these are gaseous agents. And for example, here we feel that this ovarian mass looks like solid, but actually on contrast, there is only peripheral enhancement. There is no intrinsic enhancement telling us that this area is nothing but dense endometriosis, which is giving us to solid looking lesion. So if you have a doubt whether something is really solid or cystic, we can use contrast and elastography. Then we look out for signs of adenomasses in the uterus. And by now we have n number of signs of adenomasses, non-uniformity, intramyometriosis, which is very specific. We have this Venetian blind-like appearance, ray-like appearance, scattered vascularity, softness or elastography, etc., which are very specific for adenomasses. But sometimes there can be difficulty differentiating fibroids from adenomasses. And this is where the newer techniques come into picture. Typically, fibroids are very hard on elastography, and therefore they appear dark blue, whereas adenomasses appears lighter blue because it is soft. If you do contrast, this is what happens. In fibroids, we see peripheral enhancement, and the fibroid fills up gradually from the periphery to the center centripetally, and this is known as a basket pattern. Whereas in adenomasses, we get diffuse enhancement, scattered enhancement, very quick enhancement, and this is known as inhomogeneous pattern. This is also known as a mosaic pattern, moth-eaten pattern, etc. So then, of course, we start looking at endometriosis. And before we go to the pelvis, we know that endometriosis can be anywhere. Typically, we see it around the scar, we see it in inguinal area, we see it along episiotomy sutures, etc., episiotomy scars, etc. And these are easy to pick up because we use a high-frequency probe. We put the probe on the area of interest, and we look out for this hypoechoic area with vascularity. So the first step is identifying endometrioma and identifying adenomasses. The second step is what is on a transvaginal scan, we look out for soft markers. That is, we look for site-specific tenderness and ovarian mobility. That means if the patient says, okay, either dard hai, right side mein dard hai, so we would try and put our probe in that fornix and look out for that site of tenderness. So normally, when you put a transvaginal probe and you move the ovaries we know move very easily. They're very, very mobile, in fact. But whenever there is endometriosis, and especially if there are local adhesions or pelvic adhesions, the ovarian mobility gets restricted. And this is a good sign to tell us that there are indeed local adhesions around the ovary. And a very important sign in endometriosis is what is known as kissing ovaries. So both the ovaries come into the pouch of Douglas, they are very close to each other, and there is hardly any mobility. Now, this is a big clue, not only telling us that this particular cyst in the ovaries are endometriosis, number one. Number two, this tells us that there are definite local adhesions. And number three, it warns us that whenever you see this, there is a very high chance that this patient could also have deep-seated, deep pelvic endometriosis. And therefore, we need to look out for the rectum, etc., in a better way. So this is a very important sign, the kissing ovary sign. Then the third step is what is known as a sliding sign. So typically here we are looking at a pouch of Douglas. And what we do is with one hand, put the hand on the uterus, and with the other hand, put the probe and gently move the uterus. So typically, if the uterus is anteverted, your movement of the finger and the hand would be in a different direction. Whereas if the uterus is retroverted, then one would go sort of behind the uterus and try and push the uterus from one side and push it with the other side with the help of the probe. So if the sliding is present, that's a normal thing. And we say that sliding present, which is normal, of course. And typically in the pouch of Douglas, when you have endometriosis, these are seen as hypoechoic areas which are posterior to the uterus. And you can see here that this uterus is not sliding as it was sliding in a normal scan. So this tells us that there is endometriosis in the pouch of Douglas and there are local adhesions in the pouch of Douglas. So looking out for this pouch of Douglas is a very important thing, of course, because we know that this is a common sign. And this is a retroverted uterus. So what I'm doing now is putting my hand from the top and then trying to push the uterus from one side, and with the probe trying to push the uterus again and trying to see. And as you can see, this uterus is almost static. It is not moving at all, telling us again that this sliding is absent on the posterior wall of the uterus. This is a very, very important sign. So when we look at the pouch of Douglas, we also look at a retrocervical area. This is very important because this is very easily missed. And therefore, we need to specifically sort of come out little and look at the area behind the cervix. Then we go to the step 4, which is a very important and a longer step, where we look typically for deep endometriosis in the anterior compartment and in the posterior compartment. So here again, we divide the exam into anterior and posterior. And in the anterior, again, we specifically look out for bladder separately, we look for the ureter separately, and we look for the uterovesical fold separately. And when we go posteriorly, so in the anterior compartment, we look at the different parts of the bladder, the urethra, we look at the trigone, the base of the bladder, and the dome of the bladder separately. And again, we look out for this mobility. So this fold between the uterus and the bladder is very important. And we can see again whether the bladder and the uterus are sliding separately or no. This again is very important to pick up endometriosis in the uterovesical pouch or in the fold. So here typically this is how it looks like. These are hypoechoic areas which are very vascular on color Doppler. This is one of our staff nurses in Jesco who had a very bad endometriosis, and this was extending all the way inside the bladder. So you should also find out up to what layers of the bladder it is involving, so that sometimes some of these could be tackled via cystoscopy as well. Now, and as LSCS scar is a very common site of endometriosis, and typically what we see is an hypoechoic area which are vascular as compared to, say, a simple hematoma in that area or a collection. So that's an LSCS scar. That's a patch of endometriosis, and as we can see, it's extremely vascular. And when I'm trying to push the uterus and the bladder separately, we can see that there are restricted mobility in this area, and there is hardly any movement happening in this particular area. So once, as I said, once the uterovesical fold is involved, then we need to find out how much of the endometriosis is involving the bladder, which part of the bladder, and what is the extent of involvement. And that's a patient who was operated by Nitin, the same patient which I showed in the earlier scan. Then we go to the ureters. Now, typically as radiologists, we are used to looking at ureters transvaginally. This is because very often in a female, when we want to search for lower ureteric calculi like this, we do a transvaginal scan. And therefore, when you have a slightly full bladder, as I said, we don't empty the bladder when you're looking for endometriosis. We keep the bladder slightly full, and we can see the lower end of the ureter. And if there's a patch there, that can be again picked up. So here, for example, this patient had a right hydronephrosis. That was a clue. The ureter was dilated, and there was a huge endometriotic patch sitting on the ureter, and that's a surgical specimen of the same patient. Then we go to the posterior compartment, which is very important. So here again, we divide the posterior compartment into 4 parts: the rectovaginal septum, the posterior vaginal fornix, the retrosacral ligaments, and finally the rectum and the sigmoid colon. So we go step by step. Now first we look at the rectovaginal septum. Now this is a very important area because this can be easily missed. Why it is missed is because once you put the probe in the vagina, this area comes very close to the probe, and anything which is very close to the probe gets easily obliterated by the pressure of your probe. So I'll show you an example of that. So what we do here is a technique which is known as gel sorovaginography. So what we do is put in a lot of lignocaine jelly in the vagina and then put the probe on the top of that jelly so that you can see the interfaces very well. So here, for example, that's the gel pad which I have put in the vagina, and then that's my probe. With this, I'm able to see the vaginal wall separately, the rectal wall separately, and I'm able to see the rectovaginal septum very, very clearly. And therefore, if there's a patch there, I can pick it up. So that's the beauty of gel vaginal sonography. And you can see this area very, very easily because this can be easily missed. So as you can see in this slide, slight pressure with my probe, I can easily miss on this patch of endometriosis, which was seen here if I release the pressure on the probe. And that's the gel vaginal sonography. With this, you can see these layers and the folds very, very clearly. So that's an example of endometriosis in the rectovaginal fold. As you can see, this is giving rise to those irregular sort of beaks which you'll see typically on the bowel endometrium at a later stage. The other technique which a lot of people are using, especially people from Australia, is what is known as sonopodography. So what happens is typically when we do a saline sonography for, say, tubal patency, we inject a lot of saline in the uterine cavity which goes in the pouch of Douglas. So, for example, if you inject saline in the uterine cavity, it goes to the pouch of Douglas, and it is seen very well here. So, once you have saline there, that acts as a very good negative contrast to see the walls of the uterus to see the walls of the rectum, and most important, also to see the uterosacral ligaments. So in case there's a difficulty and you feel that there is a nodule there and you're not able to clearly see it on basic sonography, we can put some saline in the pouch of Douglas and see it. Or when we do a saline sonography, typically in our center, we do a lot of hypocs and saline sonographies. We always make it a point to just sort of go through the pouch of Douglas, the rectal wall, as well as the uterosacral ligaments. So this is known as sonography. And typically then we go to the rectum. Now, when we go to the rectum, again, we have to go in a very systemic manner. We have to go gradually, and we try and push the probe gradually so that we identify each and every part of the rectum. Now, it is very difficult actually sometimes to say which part of the rectum the nodule is. So what very often we do is maybe just measure it from the anal verge and say that, okay, this is so many centimeters from the anal verge. But the problem is, of course, as we will point out later, is that we cannot really go to the sigmoid colon and the transfemoral probe. We can just reach about the rectosigmoid junction. So that's an example of an involvement of the rectal wall. So now it is very important to, once you suspect that the rectal wall is involved, then it is very important to find out up to which layer of the rectum it is involved. We know that typically in inner endometriosis, something is significant if it involves the muscularis layer as well. So for that, we have another probe, and that is a transrectal probe. So with the transrectal probe, the probe is inside the rectum, and these layers of the rectal wall are very well clearly demarcated. So once you have diagnosed that, okay, that looks like suspicious endometriosis involving the rectum, and you have roughly found out where it is, then we can use a transrectal probe to find out what is the extent of the disease, what is the depth of involvement of the rectum as well. So basically, there are various signs which have been described for bowel involvement, like absence of spikes, tail or comet sign, Indian headdress sign, then the moose antler sign, etc. So we'll just look at some of these signs. So that's a classical involvement of the pouch of Douglas as well as the anterior rectal wall with endometriosis. We can see these irregular walls. So this is again classical involvement of the bowel, and this is known as an Indian headdress sign because it resembles the headdress of an Indian. So that's a rectal wall involvement, and you can see these hypoechoic areas with the hypoechoic sort of spikes intervening between them. So once you see a couple of these patients with this typical sign, then it is very easy to pick it up and we won't miss it again. So here again, after seeing this on a routine transvaginal scan, I'm doing a dynamic scan, and we can see that in this area, the movements are grossly restricted. This is again referred to as a moose antler sign. So it depends on what you imagine from the shape which you get on the rectal wall. And this was the same sort of a patient which was operated by Jai immediately after the ultrasound. Okay. So when it comes to bowel, it is very important to give as much information as possible. The dimensions of the lesion, how much is the invasion within the muscle wall, and what is the percentage of the circumference of the rectal wall which is involved, because your surgery will depend largely on that. So in the earlier days, we were not seeing the uterosacral ligaments, but now we are also focusing on the uterosacral ligaments because we now have a special technique for that. So what we do typically is go into the posterior fornix and then in a sagittal plane sweep from either side, and we can see the uterosacral ligaments as well as the torus very well. So here, for example, I'm doing a dynamic scan and I can see both the uterosacral ligaments, that's the right side, left side, and in the center we have the torus. So both the uterosacral ligaments seen very well, but we need to really look out for uterosacral ligaments as well. Especially, so therefore it's very important to go step by step so that we don't miss out on anything. So that's an involvement of the uterosacral ligaments, the patch of endometriosis. There was involvement of the pouch of Douglas also. So in fact, this paper talks of different types of involvement of the uterosacral ligaments as well. And they typically have done this study using some saline in the pouch of Douglas. So as far as ultrasound evaluation is concerned, it is very important to go step by step. Look at the uterus and the ovaries first. Then we look out for soft markers and mobility. Then we look out for pouch of Douglas using what is known as the sliding sign. And then we look at the anterior compartment separately, posterior compartment separately, separate out in the anterior compartment, look at the bladder ureters in the posterior compartment, again separate out all the structures individually. That is very important. We also have an ultrasound-based endometriosis staging system, which we don't use but can be used actually in practice to decide upon the stage of surgery or the difficulty of surgeries which the surgeons could potentially face. So here typically the steps involved are more or less like what has been described in the IDEA guidelines. So we look at various sonography signs and we put them together, and then what we do is summarize them. That means whether the ovaries are involved, whether the bowel is not involved, other pelvic structures are involved, whether the bowel is involved, and based on what all structures are involved, we say stage 1, stage 2, stage 3, which translates into a level of surgery. So level 1 surgery, level 2 surgery, or a level 2 surgery. So we don't use this in practice, but basically when we give a ultrasound report, probably the surgeon will decide upon what sort of stage the patient is. So as I said, the limitation of transvaginal scan is two. One is in our inability to look at the rectum, especially the rectosigmoid junction and beyond. Number one. Number two is, of course, training. I mean, you cannot do a simple transvaginal scan like we do for, say, for follicles or anything. When we look out for a patient for endometriosis, we need to spend time and we need to prepare the patient separately as compared to a routine ultrasound. And we need to tell the patient, okay, now I'm going to do a sliding sign, I'm going to compress. Some of them have tenderness there. So we have to be careful about that. So training and proper technique is very, very important if you want to come to a good diagnosis. Now, when it comes to CT scan, as far as pelvis is concerned, honestly, CT has a lot of limitations. First of all, the resolution of CT is not as good as ultrasound. But where it can be useful in endometriosis is looking at involvement of the ureter and looking at involvement of the kidneys. So CT gives us a broad perspective of the entire abdomen and goes beyond the range of transvaginal probe as far as the field is concerned. That's an advantage, but otherwise, resolution-wise, we have no advantage over ultrasound. MR is definitely extremely useful. Number one, it is very specific for the blood values. So we know that what we are seeing is indeed endometriosis and not something else like a soft tissue mass. Number two, when it comes to deep infiltrating endometriosis in unusual sites, for example, in the sigmoid colon, where the ultrasound cannot reach, for that matter, rectosigmoid junction, again, it's a very useful technique. It is again very useful for bladder involvement also. So as I said, that the specificity of MR is very high because it can identify that what you're seeing is indeed a blood clots and not any other soft tissue mass. That's where it scores over a lot of imaging techniques. So just a couple of examples. That's an MRI showing involvement of the uterosacral ligaments as well as the anterior involvement of the anterior rectal wall. Again, what we saw as a moose antler sign or as an Indian headdress sign can also be seen on MRI whenever there is deep infiltrating endometriosis involving the bowel as well. So here is an involvement going right up to the muscularis layer of the endometrium. You can see the layers of the bowel and the involvement very well on MRI. So that's this is where again it has an advantage, especially when you have a lesion which is high end, that we can see it better with MRI. Then we also do MRI rectal contrast. So we put some contrast agent in the rectum and we can again delineate the walls of the rectum. But again, MRI, the problem is two. One is of course cost. Number two is that if it's a non-pigmented lesion, we may not see it on MRI. Number three is whenever the lesions are extremely small or very small, they may be very difficult to see. And number four, of course, that it's not a dynamic technique like an ultrasound technique does. So if you look at a comparison between MR and transvaginal sonography, I think transvaginal sonography properly done actually is an extremely good technique in terms of sensitivity and specificity. So just like it is not advisable to dive into a deep water